Hi guys, I am Dr. Sunil Sharma. Today we will talk about Melkersson-Rosenthal Syndrome, also called Orofacial granulomatous. What is this syndrome? This is recurrent neurological long lasting disorder characterized by this is almost triad of cheilitis, granulomatosis, lip or facial fissure edema. Number one. Two is plicated tongue, also called fissured tongue, and lower motor neuron facial palsy. Okay, so this recurrent neurological long-lasting disorder characterized by cheilitis, granulomatosis, lip facial edema, plicated tongue, and fissured tongue. Most of the cases sometimes present only this cheilitis, granulomatosis, or lip or facial fissured edema. This monosymptomatic, only this symptom having MRS, Melkersson-Rosenthal syndrome, is called Measles granulomatous. Measles granulomatosis. When fissure edema confined to the only lips is called Measles granulomatosis. Sometimes you don't find this classical syndrome, classical triad. You may find the cheilitis granulomatosis and plicated fissure tongue. In 30% cases, you may also have this lower motor neuron recurrent facial palsy. So this is definition of recurrent this MRS, Melkersson-Rosenthal syndrome. Now, this is more common in female than male. Age group between 10 to 50 years of age years. Sometimes its pathology is unknown. Unknown etiology. Unknown etiology with some genetic predisposition. I have yesterday seen one case. This is rare disorder. In my 10-year practice, I have seen only 4 cases. Yesterday I saw cases, that's why I am making this lecture about Melkersson-Rosenthal syndrome. Unknown etiology, genetic predisposition. Now, the classical tongue finding is it is fissured reddish brown color. Fissured reddish brown color, mainly 2 mm depth or approximately 15 mm length. So this is the classical finding. Tongue is fissured reddish brown color, 2 mm depth and 15 mm long. You may classify one in mild form if it is a number of fissure less than 3 mild, moderate if it's between 3 to 7, and more than 7 is severe form of tongue fissure in MRS. So this is Fissured are mainly 2 mm depth and 15 mm long. They may be numbered in less than 3 to 7, or more than 7 according to grading of mild, moderate, and severe. If we talk about lip edema, it is same finding, mainly on median, that inner side, inner surface. Upper lip swelling is more common than the lower lip swelling. Then followed by face, cheeks. Cheek swelling, may eyelid swelling, or sometimes may have ipsilateral forehead swelling. Okay, so this is the sequence: upper lip followed by lower lip, cheeks, eyelid, and forehead, or maybe scalp. So this is about lip edema. Now we will talk about recurrent facial palsy. In 30% cases, facial palsy. So this is found in 30% of cases, mainly lower motor neuron type of facial palsy, that is recurrent facial paralysis, and ipsilateral is common, unilateral is common than bilateral facial palsy. So this is found in 30% of the cases. Now, how will you diagnose? Diagnosis. First, we have to rule out tuberculosis, sarcoidosis, Crohn's disease, or insect bites. So these 4 are common in DD. You have to rule out tuberculosis, sarcoidosis, Crohn's disease, insect bite. By doing biopsy, there is caseating necrosis version. This gelatin known caseating granuloma formation, or you may find giant and Melkersson-Rosenthal, giant multi-nucleated Langerhans cells. Okay, this is known in MRS, this non-caseating granuloma, giant multinucleated Langerhans cells, and HP, histopathexamination. In sarcoidosis, there is sarcoidosis is non-caseating granuloma also, but you may find out by doing SACE titer serum. You may do the test of serum angiotensin converting enzyme titer. So if it is negative, you can rule out by doing this. For Crohn's disease, you may do serum ASCA anti-saccharomycin cerevisiae antibody to rule out Crohn's disease. It is positive in Crohn's disease, negative in Rosenthal syndrome, or you would have ANCA antibodies. Other granulomatous syndrome, you may also do this ANCA antibody, anti-neutrophilic cytoplasmic antibody. Okay, it is 2 types, ANCA and PANCA. You may rule out any vasculitis syndrome also. Now, this insect bite by history, you may bite history. So for diagnosis of this Melkersson-Rosenthal syndrome is by classical symptomatology. This is must symptomatology. Classical symptoms like lip edema, recurrent facial tongue fissure, and recurrent facial palsy. So history is must. Then you will do investigation like oral examination, oral, nose, and facial examination. Then you have to do local tissue punch biopsy. Punch biopsy. You have to do chest CT scan to rule out sarcoidosis. You have to do endoscopy and anti-cervici antibody to rule out Crohn's disease. You have to, by local biopsy, you can rule out tuberculosis. Okay, then you have to do PA antibody test for vasculitis syndrome. You may do serum HLA B27 test for to rule out recurrent ulcer Bechet disease. So you have to do these investigations that is compulsory to diagnose this Melkersson-Rosenthal syndrome. Now, what is the treatment? Treatment is avoidance of allergens, which are in the orofacial edema. Okay. Now, you have to do intra-lesional steroids therapy. You may do methylprednisolone or you may give triamcinolone injection. It is given in 40 milligram per ml in multiple sites. 1 ml is injected in where the local edema exists. Okay, you may get intravenous. If it is severe edema, which you may give systemic steroids in doses of 1 milligram per kg. Whatever, methylprednisolone or prednisolone or vicinone, whatever you want to give. Surgery, local zinc application also done, and you may, surgery is only indicated, surgical part, you only for biopsy and facial nerve decompression. Here, one thing I want to tell you, facial nerve decompression, Melkersson-Rosenthal syndrome, if it is done, this should be done by middle cranial fossa approach. Why? Because if geniculate ganglia is situated first ganglia, you have to decompress geniculate ganglia better by this middle cranial fossa rather than going transmuscular approach. If you are doing transmuscular, you are doing incomplete job in Rosenthal syndrome. You have to do by middle cranial fossa approach. So thank you so much. This is the one. Welcome to Rosenthal syndrome.